Hi, this is Andrew Mellon. Thank you for clicking on this video. I just want to be able to demonstrate some of the technology and things I'll be bringing with me to help promote real-time education for the residents, for the outpatient clinic opportunity that you've lent me for the interview. I use several programs. I'm going to demonstrate using two particular programs and kind of use them real time to show you what it actually feels and looks like with residents. This program is going to be called The Brain. It's not my program. It's just a third-party platform that I use that I've been building on for a number of years. It's something that I have over 56,000 data points in so far, as an example. So some of the big main points for the video we'll say is it effectively has the whole DSM, all the medications that we use, and then lots of kind of educational documents, PowerPoints, all those kind of normal things that we do. When we're doing things with for resident comes in, they're talking about depression stuff, maybe they're not getting some information quite correct or they're not being specific or accurate enough, then I would just open up the program, put in like major depressive disorder, MDD diagnosis, DIAG, get to the section that we're talking about with the resident, be able to open up file, kind of show them the text and terminology and concepts that they should be using or thinking about. Maybe specifically when they're using some of those words, like let's say they're using something like a psychomotor agitation or retardation, they need to understand that this is an objective finding, not subjective, and then we can go over specifically what those definitions are real time. So I would say like psychomotor agitation is a restlessness due to emotional distress or purposeless non-goal directed activity. Common examples would be like pacing, wringing hands, pulling off clothing, putting it back on, these kind of things. For these kind of things, I have hundreds of definitions like this that can be done without an issue. And then maybe with the resident, they're getting a little confused, the patient's a little bit younger, and they're not sure if it's ADHD or what they should do. Is it depression? So there's always like, how are these commonly confused with each other? We talk about it like, children with irritability and frustration tolerance difficulties, with ADHD, with impulsivity and hyperactivity could be an issue and be a confusion point. But also just knowing that if both criteria are met, you should diagnose both. It's fine. And so I have differentials like this running for basically all the types of diagnostics that the DSM does. Here's like for depression. Here's for all the diagnoses in the DSM. Maybe working with the resident, they got some paperwork or heard about things like, let's say it's a woman who just had a baby, maybe their OB-GYN family practitioner who's treating them afterwards for postnatal care has done some scales they're not used to. So maybe it's like the Edinburgh. So I can go to adult scales. Here are the adult scales commonly used. Maybe they're doing, here's the Edinburgh. I would open up that file. I would talk about the actual form and what it is. We'd go over it. I also can kind of explain how it's used, and I could print them out a copy, right, so that they have it and it's a real thing. It's not just an arbitrary discussion. On all the topics for diagnoses, I'm always going to have the specific diagnostic criteria, treatment issues, research, when it's related, and patient education, source documents, things of that nature. So if we're talking about like treatments, for depression with the resident, maybe it's kind of they're a little newer to stuff, or they're not thinking about it in the way that they should for outpatient, and then they need to be thinking of terms like response, remission, recovery, relapse, recurrence, resistance, and it's like, well, what is that from? Well, largely made famous from the STAR-D trial. And it's like, okay, what's the STAR-D trial? Well, it's this particular document. It's, here's the actual research article that was originally published. Here's what the results are, things of that nature, discuss it. And then, maybe next kind of things is patients are trying to use nutraceuticals or doing kind of the less common things. And it's like, well, these are the pieces that have some evidence when we're talking about nutraceuticals and depression. And, it's based on this journal article for a meta-analysis that was done. Maybe it's just regular medication stuff, which again, like I search for them individually, but they're basically all in here. And it's got them, I'll do them by class, for example. I can give them just quick pictures if they just need to see dosing strategies, common side effects that they need to know. Maybe it's a particular patient population that they're trying to figure out. So for depression, there's some evidence that for specificity based on that. So maybe another attending or somebody, or they read about atypical features with depression. So we could, we go into that. We'll talk about that, kind of maybe medications or things that used to be talked about in that space. And then with kind of, making sure they understand what they're doing and FDA information, right? FDA approved uses of things. Maybe it's FDA approved max dosing. Yeah, I know that many people do super therapeutic things of that nature. That's fine. Maybe, let's just pick an specific example. Let's use sertraline. So I'll always have generic and then the trade names for drugs, maybe a little bit of historical information. We've got things related. It's really pharmacology. It's not just mechanism of action. Prescribing information, side effects, and then source documents. Maybe with sertraline, they know it has something to do with cytochrome 2C19 as a metabolizer, and they're like, well, what's that? So I go, okay, let's go into the P450 system. And we'll talk about these particular categories like the 2C19. Maybe they need to know about inducers, inhibitors, substrates. Maybe it's other types of information they need to know. Maybe they want to know about the particular neurotransmitter, receptor profile. So, right, it has DAT inhibition, but it also has sigma-1 binding. Well, what's sigma-1 binding? It's this kind of thing. What are other drugs that are sigma-1 binding? It's these kind of drugs. What is information on other neurotransmitters? Okay, we got lots of that information as well. And then, side effect profiles, what's special to this drug? What are its black box warnings? What are the SSRI kind of common situations when I'm talking with them as far as a group? Maybe they need to know about serotonin syndrome because the patient keeps talking about it, so we can go into that. And I could talk to them about the diagnostics, and they should know for like how ERs use the Hunter serotonin toxicity criteria as a way to be able to do this diagnostics. So you can figure it out, and then maybe they want to know about treatment of it. We'll go into that space and do that immediately. And then we talk about prescribing, right? And then, about the pills, maybe common combinations, the whole sertraline, bupropion, Wellbutrin, fluoxetine, well-off concept. Maybe they want to know just particular dosing patterns and strategies. And so, I can give different layers of that kind of information. Education, I've got things that are related to non-psychiatrists and psychiatrists, kind of depends. I have different kind of layers of information. I really enjoy building and kind of expanding and learning new topics and kind of permanently adding it to the information, at least that I've learned over time, so I can share it. I have things that are just, introductory and, videos and doing everything to cover all of the introductory topics that folks need. Maybe some topics I've got multiple versions of things that are going from medical student stuff to half-hour short lectures to just regular 1-hour versions to things that are an hour just doing cognitive testing for one aspect of it, or like the mental status exam history, things of that nature. So, this gets used real time. Maybe somebody is calling me at night. I'm doing coverage. They got an aggressive patient. They're not sure what to do. So I could do get them one of the types of lectures that I use that are just very short documents. I always give everybody all these things immediately too. It's not to just make it mine. I share all my information always. So I make these little, really rapid, small sets of lectures that are more for what I used to do. I called a psychiatry power hour. So I just do it during the lunch period for about 30 minutes at times to keep doing kind of general education with the residents, just covering major topics they need. So a person's aggressive. So what type of people could be psychotic or kind of in this space of confused? What are special considerations, right? Are they medically frail? Is this a pediatric patient, malingering, things like that? The RN calls them, and what's the kind of normal order of operations, right? We're talking environment change, oral medications, IMs, and once you're in IM world, to give like a B52 or something, then, what are the contraindications? What are the things you need to really think about when you should do it or not do it? What are the oral medication options, kind of standard IM options? What are the kind of less common, maybe state hospital or other realm of options that are used for IM, things like that. And then what do you do when it doesn't work, right? What's the next step, that kind of thing. And then all my PowerPoints, it's doing questions, interactive stuff, and I'm always adding new information at the beginning that I need to add for next round as I come across it, so that the information is always updating, at least at some frequency. So another thing I just wanted to show real quick is when I'm teaching, doing stuff for text programs where they're I strongly basically always encourage residents to build up their own intellectual capital over time, and not rely specifically on EMRs so that they just lose their information with thought phrases and stuff everywhere they go. So let's say I'm going to do an HMP, we'll do a female for gendering, so the note pops out that way. The resident does their stuff, and then maybe they're still, it's fine, but I mean they're saying like medications are actually they're mood stabilizers, right? These kind of words and things, and so I might challenge them and say, okay, well, we should know the mechanisms of action. Let's talk about it. Like trazodone does have a mechanism of action. It shouldn't just be something arbitrary. You should know that it's going to use the serotonin 2A, alpha 1, H1 is the primary receptors at low dose, and the alpha 1 and H1 is what we're going to be causing the sedative effects for it. But it still has 2A, right? So that's a basic SSRI hit. And if this person is manic and they're impatient, you don't really feel like it's appropriate to give them, fluoxetine in that space, then why would you give them trazodone, a sleeping pill? Give them something else. Give them doxepin that's just an H1 inhibitor or something else if you're going to do that. So I've got lots of types of mechanisms, actions, discussions that can be done there. I give the program specifically that I kind of share and do with them is this thing. It doesn't matter. It's just one that works. And I have starter sets and stuff for the residents that they can use. I don't know if I'll find it fast enough for this purpose. I won't. Psychiatry starter set, there we go. And so they already start off with lots of types of notes and understanding and how to use them. And so there's like the mechanisms of action, thing of that nature. And then maybe they are writing their note and they're getting confused because they're talking to me about things that might be autism, but they're not giving me the right words and stuff. It could be that we're talking about it through here, and I'm talking about the diagnosis of autism, right? And we're going through that space, and we talk about the criteria and what they really mean. Or if it's just for note purposes and they've tried their best, we've talked about it, then I'm going to put ASD-DX, diagnosis, and then we'll talk about the diagnosis in this space instead. And I'll talk to them, we'll give them information, and I'll give them the snippet so they can put it in their real note and they do it correctly, right? That sometimes, maybe the notes, they got to think about it real properly, where the mental status exam doesn't make sense at the moment because they called them on a telephone. So they just do MSC phone. It'll change it to what's relevant in that space. And now there's things you can't look at. You don't know what eye contact is through a telephone, so take it for what it is. They're doing their assessment and plan, and maybe they're kind of dealing with a consult liaison circumstance or somebody with guardianship with somebody with autism level 3 or doing things of this nature, then maybe the person really doesn't have medical decision-making capacity, so they need to really make sure that they're thinking about that. Say capacity, no, sorry, there we go. And now we talk about it, we go through stuff with them, and then I kind of give them kind of legal concepts and stuff about decision-making capacity and how they should do that. So I bring lots and lots of stuff like this. I'm super excited about my field. I love it. I'm passionate about psychiatry. I love learning psychiatry, and I hope you'll give me the opportunity to help continue the legacy of the University of Florida psychiatry program. Thank you. Have a beautiful day.